Avacta Animal Health provides Sensi test laboratory services to veterinary surgeons worldwide. Their portfolio covers a complete allergy service of tests and treatments, including allergen-specific immunotherapy, SPL for the treatment of recurrent canine pyoderma, and the new Natural Vet Care nutraceutical range. They have a new panel of equine allergy tests comprising additional UK indigenous species, providing a more relevant test for the UK and Northern European market. In 2015, Avacta Animal Health launched Pet Allergy Week, an initiative which aims to help veterinary practices raise awareness of allergies in cats and dogs, with promotional display materials and discounted tests throughout June. Their innovative multi-marker algorithm-based tests include the unique canine lymphoma blood test, which assists vets on the diagnosis and remission monitoring of canine lymphoma, a new canine pancreatic test. They also offer acute phase protein tests, which can be used to identify subclinical conditions. For more information on Avacta Animal Health, please visit www.avactaanimalhealth.com. So thank you for joining us for today's webinar. I'm delighted to introduce you to our speaker for today, Professor Richard Halliwell. Richard has served as president of both the American and European Colleges of Veterinary Dermatology, the World Congress of Veterinary Dermatology Association, and the RZVS. Thank you, Richard. I'm now going to hand over to you.
Good afternoon. The last 5 years has seen the most remarkable explosion of, of new knowledge regarding the pathogenesis of atopic dermatitis in the dog. I'm going to review some of that with you and then try to show you how this new knowledge and the new products that are available should fit in to our day-to-day management of the atopic dog. So, a bit of science to start with, I'm afraid. Interleukin-31 is a cytokine which has been identified as being a key player in the development of the itch sensation. And this was a study done by the scientists at Zoetis, who identified, cloned and expressed interleukin-31, produced it in recombinant form, and then used it to inject animals and to see what happened. And the key findings on the right-hand column, you'll see that pruritic started within 4 hours in 11 out of 12 dogs, returning to baseline at 24 hours. And interestingly, the pruritic behavior varied between different animals. Some scratched, some shook their heads, and some licked. And I think we all have experienced different manifestations of pruritus in our clinical patients. Interesting is head shaking, because you're all familiar with the very common presentation of otitis as a key sign in atopic dermatitis. So that might have to do with the site of action of interleukin-31. And the 2 controls injected with the vehicle showed no response. So then the scientists looked at the levels of interleukin-31 in various disease states. And down at the bottom, you will see dogs with spontaneous atopic dermatitis. Over half of them had detectable interleukin-31. Flea allergic dogs, symptomatic with fleas, did not. And so it seems to be that interleukin-31 is very specific for inducing itch in atopic dermatitis. So what is the next stage in this puzzle? The scientists then looked at the sites of production of interleukin-31 and, importantly, the receptors for interleukin-31. And the key findings relevant to this discussion are that secretion of interleukin-31 from peripheral blood mononuclear cells was increased if the animals were allergic to house dust mite on the addition of house dust mite extract. And then finally, receptors for interleukin-31 were strongly expressed on dorsal root ganglion cells, which of course mediate the pathway to the itch sensation. So in this slide, we can see interleukin-31 entering the cell via the receptor and ready to trigger the itch sensation. How could we interfere with this pathway? Well, we can interfere with the Janus kinase pathway, which is responsible for introducing the IL-31 into the cell, and that, of course, is where Apoquel or octocitinib comes into play. Or, looking to the future, we could block that receptor with an antibody to the receptor, or possibly even we could use an antibody to mop up the interleukin-31 in the circulation. These things may seem fanciful, but actually they are happening. This was a study in man where they produced an antibody to the IL-31 receptor in human patients with atopic dermatitis. And they undertook a clinical trial, and they found that, yes, these patients did get some relief by blocking that receptor with an antibody to the receptor. And then, very excitingly, and more important from our point of view, is this patent application from Zoetis, the canine atopic dermatitis immunotherapy, or CADI. And here they've produced a monoclonal antibody to interleukin-31, which they are currently putting out to clinical trials in the United States. So obviously, if we can mop up all the interleukin-31, then hopefully the itch sensation will disappear. So these are extraordinarily exciting advances, and one can be proud as veterinarians to recognize that we are actually in the forefront, even perhaps ahead of human medicine in this research. Now then, let's go on to see how these things, or particularly Apoquel, fits into our clinical practice. A note of caution, firstly. This is a little article that appeared in the Veterinary Record about the supply of the canine pruritic product that Zoetis market, which of course is Apoquel. In this little article, if you read this, you would be forgiven for believing that this was a treatment for pruritus of all types. It says supply of canine pruritus product boosted. Nowhere in this is there any indication of precisely what you should use this product for. So Apoquel is licensed for the treatment of clinical manifestations of pruritus associated with allergic dermatitis in dogs, and the treatment of the clinical signs of atopic dermatitis in dogs over 12 months of age. So no, I'm not suggesting that Zoetis are deliberately misleading us with that previous paper in the Veterinary Record, but one can see how people can get the wrong impression. You should not be using Apoquel for each and every dog that comes into your hospital that has pruritus. How safe is Apoquel? Well, this was one of the original studies, and up until day 16, these let me just get the pointer. These adverse reactions were seen, which were no more significant in numbers than those appearing in the placebo. After day 16, there was no placebo. There were a whole lot of reactions, but we still don't know whether they were present in greater than the expected incidence. And Zoetis later undertook a long-term trial for a mean period of 279 days, and they found in that 10 dogs out of 247 actually had to be euthanized for malignant neoplasms. Now, we have no idea, of course, whether that is greater than the number you would have expected to have been overtaken by malignant neoplasms during that period of time. But I think it's too early to say that Apoquel is a drug without any evidence of side effects. I think the jury is still out, and more trials are needed before one can be completely reassured that it has absolutely zero side effects. So where do we start? I'm suggesting that we don't start by reaching for Apoquel as soon as we see this appallingly itchy animal. We go back to basics. Our clinical dilemma: should we treat symptomatically or should we diagnose? I'm suggesting to you today that we should diagnose rather than treat symptomatically. A whole lot of pruritic skin conditions exist in our patients which we can identify if we develop a very careful, systematic approach, and we can take care of and cure very readily without having recourse to these more advanced therapies. The systematic diagnostic approach to the pruritic dog requires as prerequisites, of course, a full history, and it's helpful, I think, if you have for your clients, when you're going to see a derm case, you have a little questionnaire form that they can fill out with the important essentials before you get into the room with the patient. And then a thorough clinical examination of all the body systems. And then cytology, which can be enormously helpful as you approach the diagnosis of your patient. Cellulose acetate tape strips are, I think, the most simple, cost-effective approach of all dermatologic armamentaria that we have. And then, of course, skin scrapings, both superficial and deep, from any abnormal skin. Cellulose acetate tape strips, you press the tape onto the lesion, and then you will stain it. Do not fix it because it will destroy the cellulose acetate. And then you put it on a slide without fixing, but with the stains, and then you examine them under the microscope. And you will look for bacteria, you look for malassezia. And then skin scrapings. It's surprising what you can find when you're not expecting it. If you don't scrape, you won't find it. And of course, there is a technique for doing skin scrapings which will maximize your return. You do superficial and deep skin scrapings as two separate exercises because some parasites, such as Chiletiella, are very superficial. Others, such as Demodex, are deep. And with scabies, actually, we have the male on the surface. You'll pick that up with superficial scrapings. And we have the female down in the epidermis, which you'll find with deep skin scrapings. Squeeze the skin site first if you're doing a deep skin scraping. Moisten the skin with oil. Do broad superficial scrapings first. Then return to the same site to undertake deep scrapings to capillary bleeding. So that's our diagnostic approach, and I'm going to suggest to you that every derm case that we see, we should put through those diagnostic approaches, the clinical history, the full physical examination, and the cytology and the skin scrapings. Now we're ready for the rule-outs, and don't forget that common things occur commonly. So first, let's rule out parasites. Well, clinical signs of flea allergy dermatitis. Of course, although we've got wonderful new products for fleas, we still have patients with flea allergy dermatitis. They don't all look quite as straightforward and obvious as in this slide, or the chronic flea allergy dermatitis seen in this slide. And in the cat, clinical signs of flea allergy dermatitis can result in any of the reaction patterns. We see here miliary dermatitis, an eosinophilic plaque, self-induced alopecia, and we see also here the eosinophilic ulcer. and also head and neck pruritus, which is recognized now as the fifth reaction pattern in the cat. Flea allergy dermatitis diagnosis requires all of the following: the presence of fleas and or flea dirt. And this little flea dirt test is terribly simple to undertake, but is often forgotten. You're not likely to see such a beautiful flea there just sitting there and ingesting blood from this patient. Presence of fleas or flea dirt, compatible clinical signs, demonstration of hypersensitivity. If you skin test, you will look for the 48-hour reaction as well as immediate reaction. And because a significant proportion of animals with flea allergy dermatitis suffer from delayed hypersensitivity only, the immediate hypersensitivity reaction is negative, so your serology for IgE will be negative. And then response to parasiticidal therapy. Trombicular, don't forget trombicular, or berry bugs as they call them in Scotland. Larva is parasitic on mammals. They breed in decaying organic matter, just visible to the naked eye as orange dots. Clear seasonality, and the season seems to be extending with climate change. And the feet and ear flaps, the notches of the ear flaps are particularly affected. And of course, it also affects people. And here is a trombicular larva. And then lice are, I think, much less common than they used to be 30 or 40 years ago, but you will still see them from time to time. Of course, they can be a significant cause of anemia, as well as seeing the nits and the lice on the fur, on the hair coat. Biting lice and sucking lice. Demodex is normally a non-pruritic disease unless there's secondary infection in the pustular form. And here, the Scotty that you can see had significant pruritus from the secondary infection. And Demodex cati in cats, again, is generally non-pruritic. This is actually more common than people think. It can be in the ears, it can be little lesions around the mouth, or it can be more generalized. And here we've just plucked some hairs and we've seen them on the hair shaft. There is a rare pruritic form of Demodex called Demodex gatoi, and this is a slide of Nicola Halliwell, my daughter, who saw this patient in Hong Kong. It is reported in the United Kingdom. It's not that common. It's a shorter mite, and it can cause significant pruritus. No prizes for guessing what this patient has. Of course, this was actually a dog that the students at Edinburgh adopted from some local gypsies, and it has scabies. But scabies can be a very difficult disease to diagnose. And I like to approach the diagnosis in two stages. One, raising the index of suspicion. Is there a possibility of contagion? Where could this animal have acquired the infection from? Is it a puppy that came from a puppy shop, kennels, a vet's office, dog shows, or in the countryside from exposure to foxes? Are other animals affected? Long hair can be protective. If you have a long-haired animal, you can have one animal with scabies in the house and the other doesn't catch it for several months. And of course, are the owners pruritic? You can see these lesions around the trunk of this owner of a patient with scabies. And my favorite case where I saw pruritic owners affected was when I was in practice in London, and Zaza Gabor was one of our clients, and she invited me to her hotel. She had just purchased a little Pekingese that seemed to be itching, and I said to her, Miss Gabor, can you tell me, are you itching? And she said to me, she said, yes, doc, do you want to see? Well, Zaza Gabor used to go to bed with this animal on her breast, so you can understand how embarrassed I became shortly afterwards. Are the lesions and distributions compatible? This penile pedal reflex is positive in 82% of patients as compared to 6.2% of other pruritic diseases. A very useful, simple little test where you just rub the ear margin and you see if the back legs will reflexly start scratching. And is the disease partially corticosteroid responsive? I'm not suggesting to you that every patient that you think might have scabies, you should try treating with corticosteroids to see if it's only partially responsive. But if you happen to have a patient that has been treated and has not resolved completely, then you certainly need to consider the possibility of scabies. And then, of course, confirmation of the diagnosis, multiple broad superficial skin scrapings for the male, deep scrapings for the female. But generally, however well you do it, you'll only find it in about 50% of cases. Easier to find in steroid-treated patients, and abundant in so-called Norwegian scabies, which is characterized by excessive scaling and crusting, and probably represents a failure of the immune response to scabies. Then there's a serological test for scabies-specific IgG, and there's some controversy about many aspects of this. How quickly do we become positive once the animal's infected, and how long does it last after the animal's treated? And I think it's a very useful test, but as to whether it's actually 100% sensitive and 100% specific, I think the jury is still out. And then finally, of course, if in doubt, treat. Here's a nice scabies mite, and these are the little fecal pellets. Sorry, here, if I can get this, here's a scabies mite, and here are the fecal pellets. And here are the eggs you can see in the little burrow in the crust. Notoides cati or feline scabies is certainly very uncommon. I've not seen a case in the United Kingdom, but it is very common in southern Europe, Spain and Italy particularly, and in some parts of the United States. Limited geographic distribution for feline scabies, mostly southern Europe, may cause transient lesions in humans, affects the head and the ears, but may spread over the whole body surface. And it's easily demonstrated in skin scrapings, as opposed to canine scabies. And then don't forget Chiletiella. This was a Seborrheic Cocker Spaniel that came to see me for its seborrhea, but actually when we clipped a little bit of the hair coat away, you can see abundant scale, more scale, and of a different type than you'd usually expect with Cocker Spaniel seborrhea. And here we have the Chiletiella mite. And again, Chiletiella, two phases. One, raising the index of suspicion. Are the owners affected? Because they can be affected as well. Or are the dogs in the household affected? Whence could the patient have acquired the infection? Walks in the countryside with rabbits, contact with other dogs, shows, etc. And I'm afraid, again, also the veterinarian's office. Are the clinical signs compatible? Generally, we will see truncal scaling. And then the diagnosis, hair pluckings to look for eggs, tape strips you can do to look for the mite on the surface. It's a surface mite, very superficial skin scrapings, and be sure to moisten the skin before you scrape. Otherwise, the mites will all disappear off into the environment with the scale. And again, if in doubt, treat. Tick infestation. Ticks may be a cause of granulomatous inflammation, and also the small 2 to 5 millimeter larvae, or so-called seed ticks, can be a cause of moderate to severe pruritus. Here you can see significant erythema at the site of this tick bite, and a circular pattern of granulomatous inflammation around the site of the bite. And this animal has granulomatous lesions, almost neoplastic-like on the nose, and this was attributed to tick bites. Here's a Labrador with atopic dermatitis before presentation, here with a very, very severe secondary staph infection. After successful immunotherapy, the staph all went away as well. Certainly some hyperpigmentation there, perhaps suggestive of hypothyroidism. But the dog went away and came back 6 months later, or a year later, excuse me, having relapsed. And no, it was not the atopic dermatitis that relapsed. It now had an infestation of seed ticks, and you can see one just there, and you can see other small little seed ticks on the skin. And so this emphasizes to us that if we have an atopic dog that is not doing well on immunotherapy or on other treatment that we've prescribed, don't assume that it's just failing to respond to its atopic dermatitis or relapsing from its atopic dermatitis whilst on the same treatment. Reassess it and see if there's some other cause, other explanation for the pruritus. Otodectes cyanotis. I don't know why it is that whenever I take pictures of otodecs, they seem to be copulating, and they still continue to copulate under the oil there. Primarily an otic parasite, but it may spread out from the ears over the neck and trunk and cause more generalized pruritus, particularly in the cat, but occasionally in the dog. And there's a well-demonstrated hypersensitivity state in the cat. So not commonly outside the ear, but sometimes it certainly can cause problems. Okay, we're working down the list. We've ruled out most parasites. We now assess for microbial overgrowth, which can be very pruritic. Malassezia dermatitis. 15 years ago, 20 years ago, nobody knew about Malassezia dermatitis. And we obviously, it was been there all the time, but we just failed to diagnose it. Usually affects glabrous parts of the skin, often associated with hyperpigmentation and with very, very much inflamed skin, hyperkeratotic skin, and a lot of greasy exudate. And here's crusts and exudate around the lip of this cat with Malassezia and interdigitally. Lichenification. Lichenified lesions often are associated with Malassezia dermatitis. So overgrowth is diagnosed by showing greater than 2 per high-power field or greater than 10 in 15 randomly selected high-powered fields. It's almost always secondary to an underlying disease, and the contribution to the disease is highly variable, probably relating to whether or not the animal is hypersensitive. Sometimes you'll be treating an animal with Malassezia dermatitis. The Malassezia will all go away, but the pruritus remains. So that's obviously indicating that the Malassezia was not contributing to the pruritus. The contribution to the pruritus is highly variable. And lovely peanut-shaped organisms as seen in this slide. Bacterial overgrowth. Again, people, I think, are becoming more and more concerned about the relevance of bacterial overgrowth, which 20 years ago was not diagnosed. Here you see a tape strip with very, very beautiful cocci on this keratinocyte. And that's a sort of lesion that you might suspect bacterial overgrowth in the intertriginal areas or interdigitally. And again, you'll get scale and you'll get exudate. Now, I suspect that a lot of cases we see have both bacterial overgrowth and Malassezia overgrowth affecting the same lesions, because they do tend to look rather similar and they will appear as secondary complications to underlying diseases. Then we will look for staphylococcal folliculitis, which can take many, many different forms, little pustular lesions, little papular lesions, crusting lesions, and scaling lesions with hair loss. And this can be significantly pruritic. Special considerations from the cat, we've got to rule out psychogenic alopecia, which is most commonly seen in Burmese and Siamese, and usually symmetrical down the back, or can be on the flank. How common is psychogenic alopecia? Well, there was a very interesting study recently done in Guelph in Canada. Psychogenic alopecia was diagnosed by failure to respond to methylprednisolone acetate and by response to 0.5 to 1 milligram per kilogram of clomipramine. Food allergy was diagnosed by response to Hill's ZD and response to challenge, and flea allergy was diagnosed by response to parasiticidal therapy. So, of 20 cats referred to the University of Guelph with psychogenic alopecia, there were only 2 at the bottom here that were actually found to be suffering from psychogenic alopecia alone. Some had a combination of allergy with psychogenic alopecia, but notice how a great number actually were adverse food reactions with atopic dermatitis, adverse food reactions alone, or atopic dermatitis alone. So psychogenic alopecia does exist, but it's uncommon and I think very much overdiagnosed. Now, just to emphasize that not one of the pruritic conditions described above would be expected to respond to Apoquel. So no, Apoquel is not a treatment for pruritus. It's a treatment for allergic and atopic dermatitis. Working our way down the list, we've eliminated parasites, we've eliminated bacterial infection, malassezia, bacterial overgrowth. We are left with 3 possibilities. Is it an adverse food reaction, atopic dermatitis, or is it a combination of the 2? What's the relative incidence of the 2? Well, this was a study done by Hilary Jackson when she was at North Carolina. CAD is atopic dermatitis. 46% were atopic dermatitis alone. AFR, adverse food reaction, 23%. So adverse food reactions are about a half as common as atopic dermatitis from environmental allergens, and a combination of the 2 in 21%. So I think we probably over the years have underdiagnosed adverse food reactions. What are the factors that increase our index of suspicion for an adverse food reaction? Well, this was some very good data from studies in Switzerland, which contrasted atopic dermatitis due to environmental allergens and adverse food reactions. And they showed that adverse food reactions tend to commence earlier in life, 48% commencing below 1 year of age, as opposed to 16% of cases with atopic dermatitis. There's a higher incidence of concomitant GI signs in cases of adverse food reaction, more malassezia with AFRs, no seasonality, which there may be with atopic dermatitis. And in addition to the breeds overrepresented for atopic dermatitis, like your terriers, the German Shepherd, Pug, and Rhodesian Ridgebacks are specifically predisposed to adverse food reactions. So, if you have a 6-month-old Rhodesian Ridgeback come to your office with signs of allergic reactions, pruritus, then adverse food reaction is right at the top of your list of differentials. So let's first eliminate an AFR by response to up to 8 weeks of a hypoallergenic diet trial, followed by a dietary challenge. Now, why up to 8 weeks? Well, because some animals take that long to respond. How can I control the pruritus in the meanwhile? Perfectly acceptable to give a short 1 to 2 week course of prednisolone or something like that to control the pruritus, and then withdraw from the drug whilst you're on the elimination diet to see if the diet alone will work. Which protocol? You could have limited antigen commercial diets, which are not terribly useful because they contain a lot of other things often as well. Hydrolyzed diets, yes, very useful, but so far there's been no hydrolyzed diet that's been proven to be 100% in terms of picking up adverse food reactions. 85%, 90% perhaps, but not 100% as of yet. Home-prepared single-source protein diet following negative serology. This, I think, possibly is still the gold standard. Serology for foods is not diagnostic. You cannot use serology to make a diagnosis of food allergy. But what you can do is use serology to guide your selection of which protein source to use in your hypoallergenic diet trial. If your patient is negative to serology for IgE and IgG to a single protein source, you have a greater than 80% negative predictive value. So this will be very helpful for you in choosing the right hypoallergenic diet trial. And then you must follow with a dietary challenge. There are many, many patients around the world which have never had the dietary challenge and have remained on the hypoallergenic diet. And so the food allergy or the adverse food reaction was never proven, it was just suggested. Still negative, we've ruled out adverse food reactions. We are now faced with a diagnosis of atopic dermatitis, which is a diagnosis by exclusion. So we'll reach that at the end of the road, but we must go through all these other possibilities so that we don't miss anything out on the way. But does the clinical picture fit? What does our atopic dermatitis patient look like? Well, again, this was work done in Switzerland. The 10 clinical criteria identified by Claude Favreau and his colleagues as most suggestive of atopic dermatitis are onset less than 3 years of age, whereas food allergy, the peak onset is 1 year of age or below, mostly indoor, corticosteroid responsive pruritus, chronic or recurrent yeast infections, affected front feet, affected ear pinnae, but non-affected ear margins. So you will expect to have an otitis that's affecting the vertical ear canal and the inner aspect of the ear pinnae, but not affecting the ear margins. That, of course, is to exclude scabies. Non-affected dorsolumbar area to exclude flea allergy dermatitis. And in the early stages of the disease, pruritus without lesions. Your early case of atopic dermatitis, when you first see it, there will be nothing there to see, perhaps a little bit of erythema, but all the lesions come later on and with secondary infections and so forth. Why test for allergen-specific IgE? Do we want to test for allergen-specific IgE? Firstly, let me emphasize we cannot make a diagnosis of atopic dermatitis on the basis of allergen-specific IgE, because a lot of normal dogs will have allergen-specific IgE and normal people, particularly to house dust mite. So let me emphasize a positive intradermal test or a positive serology for allergen-specific IgE is not a diagnosis of atopic dermatitis. Why do we do it then? Well, it aids in the selection of allergens for immunotherapy. It may help to identify allergens for elimination from the environment. Particularly, of course, one's thinking of house dust mite, and there are clinicians who believe that environmental control of house dust mites in atopic dogs can be helpful, but importantly, it takes several months before it will work, because the allergen remains long after the mites have been dead in the environment. If IgE testing is negative, then we need to carefully reassess the diagnosis. And if we're confident that, yes, this is atopic dermatitis, but we have no allergen-specific IgE, then we have a diagnosis of atopic-like dermatitis for which there are no allergens involved. So we cannot use immunotherapy for these cases. Whether or not these cases still will respond to Apoquel or to any of the other treatments for atopic dermatitis, I think the jury is still out. There's not a lot known about atopic-like dermatitis, but it certainly is a clinical entity. Well, here is our overview of the workup of the Pruritic dog. Pointers from the history and the physical examination. And yes, we're not going to probably make a diagnosis right there. Store for later use. Cytology and skin scrapings may be diagnostic or store for later use. Assess for parasites, coat brushings for fleas and for flea dirt. They may be negative. Assess for pyoderma. If they were positive, then we treat, and that's the end of the story. Assess for pyoderma. If it's positive, we treat, and if it's cured, that's the end of the story. If it recurs, then we're back on this trail, and we've got to assess for adverse food reactions. We may get a partial response, in which case we'll still assess for atopic dermatitis, believing that maybe we've got one of those quite common cases that's a combination, or if there's no response to the AFR workup, then we assess for atopic dermatitis. If we've assessed for atopic dermatitis and there's a complete response, we have a diagnosis of an adverse food reaction, and we need to then maintain the patient on a hypoallergenic diet. Now, although I think that I certainly like a home-prepared diet for diagnostic purposes, having made the diagnosis, I certainly prefer to go to a commercial diet, which will be a better balance for maintenance. So, if we have a partial response to AFRs or no response at the AFR challenge, we assess for atopic dermatitis. And we have either a diagnosis of atopic-like dermatitis if IgE serology is negative, or of atopic dermatitis plus or minus food allergy if serology is positive. Right, now we've made a diagnosis of atopic dermatitis. We've eliminated everything else. We've eliminated food allergy. And how are we going to treat it? And this is another depiction of the IL-31 pathway, showing where the various therapeutic modalities act. If we first look at the pathway, genetics are fundamental in determining whether you're going to be an allergic dog or not. And allergens, the properties of allergens, some are more allergenic than others. And adjuvant events such as vaccination at the same time as you're exposed to an allergen will help make IgE antibodies. And this develops because of what's called Th2, T helper cell 2 polarization. We have the allergen, then we have Th2 cells, we have skin-homing T lymphocytes in the skin, and we have IL-31 produced. And importantly, it goes to the dorsal root ganglia, goes to the keratinocytes, mast cells, and macrophages. Where do these treatment modalities act? Well, immunotherapy up here acts on the Th2 polarization. Cyclosporin acts on the Th2 polarization, also on the skin-homing T lymphocytes in the dermis. What about topical corticosteroids such as hydrocortisone acetonate? This will act on the T cells in the skin, the Th2 cells and the skin-homing T lymphocytes. What about systemic acting corticosteroids? Well, these act everywhere. They act up here, they act at every stage, and so it's not surprising that they are very effective. And what about canine atopic dermatitis immunotherapy? This is the CADI-1 that's undergoing clinical trials in the United States. This will act just by mopping up all the IL-31 in the circulation and preventing it, therefore, from getting to the dorsal root ganglia where it's going to cause the itch. Now, what is the relative efficacy of all of these treatments? Unfortunately, corticosteroids are close to 100%. And of course, we know very well that they have significant side effects, which is why we wouldn't want to use them long term. Hydrocortisone acetonate or topical steroids will be very effective for topical treatment and preventing relapse when used in the favored areas for the sites of involvement of atopic dermatitis. And immunotherapy, cyclosporin and Apoquel or octreotide are all about the same efficacy at about 60 to 70% efficacy. So they're all much the same efficacy. How effective canine atopic dermatitis immunotherapy is going to be remains to be seen. So we've emphasized these very exciting new developments in our understanding of atopic dermatitis and the pathogenesis, and the extraordinary advances where the veterinary profession and veterinary research has really led the way, reaching the goal even faster than our human dermatology colleagues. And we've emphasized, I think, how you must rule out these other causes of pruritus before reaching a diagnosis of atopic dermatitis. It is a diagnosis by exclusion. You've got to exclude every other possible cause of pruritus along the lines that we've indicated. And if you can adopt, if you haven't already adopted, this scheme of going through things in a logical, sensible way, I would urge you to do it, because you will, I think, end up with far better results for your patient if you can do it that way. Thank you very much. Here we are. Here's some questions. When serology for atopy is negative, can't it be due to the antigen in the testing panel? Yes, certainly that is a possibility. Every laboratory marketing allergy test hopes to have a panel that is tailored to the particular region or particular country where that test is offered. But it's probably impossible to include every conceivable allergen in the test. So yes, it could be that the allergen has been left out, in which case we need to know about your thoughts on this so that perhaps the laboratories can include the allergens. Which do I prefer, intradermal skin testing or serology? Well, that's hard to say. I think they both are extremely useful. It used to be said that the gold standard was intradermal testing, but some recent studies done in the United States have shown that the reproducibility and variability of intradermal testing in different hands really makes one suspicious of this concept that it is the gold standard. I think that they're probably equivalent. And actually, in Favreau's work, serology was slightly better as a diagnostic aid than was intradermal testing, but I don't think we can read too much into that. I think that they are both extremely valuable, and I couldn't really put one over the other. Can you please repeat the flow chart on the IL-31 part, the flow chart? Let me see if I can go back to repeat that. Hang on. Yes. Okay, there it is. What are the chances of atopic? Well, that's another very good question. What are the chances of atopic dermatitis being as yet unidentified allergens? That certainly is possible. We really know very little about this condition. There is some suggestion that there is a different genetic pathway, a genetic susceptibility, in that French bulldogs, work done by Pascal Prelode in France, that French bulldogs appear particularly susceptible to it. But yes, we don't know much about it. But of course, in humans, there's intrinsic asthma, which is not related to any allergens, and extrinsic asthma that is related to allergen provocation and challenge. And it's the same with atopic dermatitis in people. So, you know, there's a precedent for having a non-allergy, allergy-like disease in dogs, as there is the same thing in people and in asthma in people. How can food serology not be diagnostic? I can't quite read the whole of the question. How can it not be diagnostic? Well, I think it's possibly the case that we haven't refined serology for food antigen-specific IgE sufficiently as of yet. Because what they've done in people, they have developed defined cutoffs for levels of allergen-specific IgE that are clinically significant and clinically diagnostic. And below those levels, they are not of any clinical relevance. So it may be that we haven't reached that stage, and it may also be, of course, that not all food allergy is IgE mediated, which I think is probably also the case. So it's a puzzling situation, but one that I think we will be learning more about as research goes on. Amount of time off corticosteroids before allergy testing. Well, for serology, it is not as critical as it is for intradermal testing. But generally, and it depends, of course, the type of corticosteroid and how long it's been on for. But generally, for intradermal testing, we say 1 week off for every month of steroid usage. And for serology, again, it very much depends upon the length of time, probably about the same, a week off, maybe a week off for every 2 months is sufficient, unless you've got very high doses of corticosteroids. If you have a patient on alternate day, low-dose alternate day prednisolone, for example, that you're maintaining, you can probably get a valid serology result taken without removing the patient from corticosteroids. So if it's alternate day low dose, probably okay right away. Otherwise, about 1 week for every month. Any evidence of chicken allergy in pit bull type dogs? Not that I'm aware of. If the response to octocitinib is poor, does it suggest the wrong diagnosis? I would actually say it probably does. I would say it probably does. As far as we know at the moment, Other pruritic diseases, such as flea allergy, don't produce IL-31 in such quantities, so octreocitinib would not be expected to work. But yes, I've almost suggested to people to use Apoquel as a diagnostic aid for atopic dermatitis because its action is so very, very specific. What would you use to treat harvest mites? Almost anything except imidacloprid. Fipronil is fine for harvest mites. Almost any parasiticide is effective. Harvest mites. Would amitraz be used as the most immediate and reliable? Oh, amitraz dips. What, for Demodex, I suppose we're talking about. I hope we're talking about Demodex. Well, I think that you should use amitraz as it's a licensed product. I think that some of the newer parasiticides that are just coming on the market will be shown to have wonderful efficacy against Demodex. And of course, moxidectin imidacloprid or Advantage Multi or Advocate is a very effective treatment where we've got the mixture of moxidectin with imidacloprid. Do you recommend hydrolyzed or single protein diet? Well, at the moment, I think the jury is still out on the hydrolyzed diets. It's about at 85%, but I know there's work going on to modify some of these, and it's quite possible that some of the newer diets may be shown to be 100% effective as diagnostic aids. But at the moment, I don't think you can better a single source home-cooked protein. Would you ever use Apoquel as an add-on therapy for dog immunotherapy? I don't see why not, actually. I don't see any contraindication to using Apoquel along with allergen-specific immunotherapy because they work by different mechanisms. Apoquel is just blocking the IL-31 receptor, and of course your immunotherapy is acting way back, further back in the cascade. So I see no reason why you shouldn't use a combination of the two. Well, I think we're about out of time, so I think it's probably time to say goodbye and to thank you very, very much for your attention this afternoon.
On behalf of Webinar Club, I'd like to thank Professor Halliwell for an excellent presentation today. The recording and the certificate of attendance for this webinar will be available in the next few days, and we will email you as soon as they are ready. Thank you all for attending. That's the end of the webinar.